Hello everyone. We've reached the hour of 1 o'clock, so let's get started. I want to thank you for joining us today. This webinar is presented by NCCHPP and NCCDH. Before we get started, I just want to make a couple of reminders. We're scheduled for 90 minutes today, and that means we'll have lots of time for discussion. We'll plan to go for the whole 90 minutes, but we'll also play it by ear, so if we don't need the whole time, we might sign off a little sooner. But it will really depend on how the conversation goes. And if it's rolling, we'll be very happy to stay online with you till 2:30 Eastern Time. Another reminder, we are recording this webinar today, and your name and comments that you make in the chat box will be visible, so please bear that in mind. We will post this PowerPoint and the recording of this webinar online, and we'll send a link for those to you by email after we're finished today. My colleague Mylène McGuire is also on the line today to help with technical matters, so if you encounter any trouble, please write her a note. She'll do what she can to help you out. And thanks, Mylène. We can't do webinars without you. Okay, we're glad that there are a lot of people on the line. It looks like we have, how many already? There's still people coming in. We've got over 100 and more on the way, I think. However, that means we cannot open up the phone lines today. However, at the same time, we want you to be an active part of the discussion with us today. So please use the chat box at any time to ask us questions, to make comments, and to add your own experience and expertise to this discussion. We'll keep an eye on the chat, and there will be several pauses to address questions as we go. If things go well, there will be a lot more going on in the chat than we can actually keep up with. But we'll do our best to address what we can during the webinar, and we will also review all of the chat afterwards. And if it appears that we need to do a follow-up on something, we will definitely do that. If we do that, we'll let you know by email. The point being, please write and please participate. My name is Michael Keeling, and I'm with the National Collaborating Center for Healthy Public Policy. I'm here with my colleague Sume Ndumbe-Ayo from the National Collaborating Center for Determinants of Health. This webinar, as I mentioned, has been jointly organized by the NCCHPP and the NCCDH. We are very fortunate and pleased to be joined by Dr. Bernie Pauly today. Sume will properly introduce her in a moment. We also want to, before we get going, acknowledge and thank Leslie Dyke, who helped us to organize this webinar. None of us has a conflict of interest to declare. Back when you registered for this webinar, we asked you a couple of questions about your level of knowledge about health equity and about public health ethics. Here's a summary of what you said. On the health equity side of things, it seems that the group is fairly knowledgeable about both, health equity and about putting equity into practice. But it does seem a bit as though people are more familiar with the health equity side of things than the practical side of things. Just a little less comfortable with putting it into practice. And on the public health ethics side of things, you said that you were knowledgeable, perhaps a bit less so than you are with equity. And we have the same pattern here between the two graphs. More comfortable with the public health ethics part of things than with the practical aspect. In this case, approaches for identifying ethical issues. It's clear in any case that there's a lot of experience and expertise on the line, so we hope that you'll share that in the chat as we go. Our national collaborating centers are part of a network of 6 NCCs across Canada, and these are financed by the Public Health Agency of Canada. The NCC for Healthy Public Policy has a mandate to support public health actors in their efforts to promote healthy public policies. Those are policies that are not necessarily focused on health, but that influence health all the same. These policies might relate to income, to education, to public infrastructure, to nutrition, and so on. We work on various ways of helping the public health sector to identify the health dimensions of those policies and then influence them to improve population health. Our interest in public health ethics stems from our view that ethical literacy is a key part of any public endeavor, and that includes policy making, and it certainly includes public health at every level. So with that, I will pass the microphone over to Sume.
Hi, and thanks, Michael. Good afternoon, everyone. This is Suman Dumbe Ale with the National Collaborating Center for Determinants of Health. We, as Michael mentioned, we are one of the entities putting on today's webinar, and our particular focus and interest is on the social and economic conditions that affect health and how we work together to reduce the gap between the most and the least healthy, as well as along the social gradient, which we see across a wide range of health issues in our society. We work primarily with public health practitioners, decision makers, and other stakeholders to translate and share evidence related to the determinants of health and health equity. And so before we get started, we'd like to get a sense of who is on the line. Michael mentioned we had over 100 people. I see we're at about 120 plus. So what province are you calling in today from, or where do you work? Excellent, thank you. All right, so I see we have a ton of people from Ontario, about 50%, Alberta, BC, Manitoba, Newfoundland, a few international people, welcome, Quebec, Saskatoon. So we have people from almost every province and territory here. It's great to have you on today. So I'm now going to introduce our speaker for the day, who is Dr. Bernie Pauly. Oh, before I do that, I'll go to today. So as Michael mentioned, really, today's webinar is focusing on the everyday ethical issues. And as you could see from the slides he shared earlier with regard to what you told us, most of us really don't spend as much time or have as much expertise in dealing with everyday issues as they play out in public health practice, especially with regards to health equity. So how do we make decisions about what we act on and how we act on that? So that's really going to be our focus today. And through Bernie's presentation, we're going to learn how public health practitioners in different sectors talk about these issues and how they navigate them, and also a range of resources and strategies which you could use in your own practice to help you address some of these ethical issues which you may face in your work. And as we listen to Bernie's presentation, I really like to encourage you all to think about which of these actually resonate with what you are experiencing, and which other ethical issues are you dealing with, and raise those in the Q&A period. So before Bernie starts, I'd just like to introduce her. So Dr. Bernie Pauly is a nurse and a scientist and associate professor at the University of Victoria. She studies policies and programs that improve the health of individuals who are affected by this social circumstance. She's a scientist with the Canadian Institute for Substance Use Research, a member of the Renewal of Public Health Services Research Team, a priority lead for the Canadian Observatory on Homelessness, and at the University of Victoria, she is a Provost Community Engaged Scholar and a Scholar in Residence at Island Health. The primary focus of her research is reducing health inequities associated with substance use, poverty, and homelessness. Today she'll be speaking about research conducted as part of the Equity Lens in Public Health program of research, also known as ELPH, which is funded by the Canadian Institute of Health Research. That particular research project, the ELPH project, really aims to produce new knowledge for reducing systemic health inequities and for promotion of health equity through mental health promotion and prevention of harms of substance use. So welcome, Bernie. Really thrilled to have you on the line with us today, and it's on to you. And Bernie, if you need to unmute yourself, you can do that using *6 to unmute your line.
Thanks, Sume. I was doing such a beautiful introduction to my talk.
Sorry, we missed that.
Thank you. As you can see, Sume and Michael are very, very skilled at facilitating this work and the session. I just want to begin by acknowledging that I'm located on the unceded territory of the Coast Salish people, and the University of Victoria is particularly located, and I want to acknowledge the Lekwungen, Esquimalt, Songhees, and Wasanic-speaking peoples on whose land our university sits. The session that we're doing today is around something that I feel very passionate about through my career. I actually worked for about 10 years with a team of nurses who were looking at ethical practice in nursing. But it largely focused on, it was very important work because it was looking at the everyday ethical issues that nurses experienced, but it was often in the context of acute care. And through that work, recognized the importance of looking at everyday public health ethics issues. And so, as Sume mentioned, as part of the Equity Lens in Public Health project, we had a chance to look at public health ethics issues. And you'll see on the first slide there, the team that has worked together on this particular analysis, Wanda Martin, who's from the University of Saskatchewan, Lenora Marcellus, Tina Revai, and Marjorie McDonald, and myself, who are all at the University of Victoria. I just want to begin to acknowledge as well our funders, as Sume mentioned, the Canadian Institutes for Health Research, and particularly the Public Health Agency of Canada. So public health ethics is still an emerging field that's distinct from biomedical ethics. And what makes it so distinct is that there's a focus on health equity and social justice, and puts that in the foreground for populations and not just focusing on individuals. It looks at and considers Upstream's actions on the social determinants of health, and I think more accurately it focuses on health promotion as well as prevention of disease and illness as opposed to acute care. So if we think of sort of the traditional clinical ethics, it often focuses on situations in acute care, it often focuses on situations of individuals, and it doesn't necessarily take into the context issues related to social justice and policies and programs that produce health inequities. And so very much in public health, we are concerned with both the health of the population as well as reducing or health inequities or promoting health equity. So if we look at various different sets of competencies, such as the core competencies for public health in Canada, we see that health equity is very important as both a value and an obligation. And you see there from the PHAC document, important values in public health include a commitment to equity and social justice. So this speaks to the value base. However, what's often been lacking is explicit guidance around navigating ethical issues in public health. And in fact, we really don't know a lot about what kinds of ethical issues public health practitioners face related to health equity work. So you can definitely find a literature that's about ethical issues in public health and writing about different theoretical approaches to ethics in public health. That's there. But when you go to look for ethical issues in doing work related to health equity, there is very little about that in terms of either the ethical issues or guidance around how to navigate those issues. So that's what we put together in the ELPH project. So when Michael was presenting, you know, how comfortable people felt about health equity, how comfortable they felt about ethics, we're putting both of those together. And throughout the presentation, I've got various points, which I've called discussion points, where we're going to stop and through the use of the chat box have some dialogue with you. So please, we'll look forward to that, because I want to stress that this analysis is actually a preliminary analysis, and so I'm very much looking forward to what you know, resonates with you and what's missing as well. So the Equity Lens in Public Health project is a very large, it's a almost 6-year project. We've had 4 different research projects within this large program. And the one that I'm talking about today, Power and Ethics in Public Health, is specifically related to this issue of ethics in health equity work for public health, for individuals working in public health. The Equity Lens in Public Health project is a collaboration of BC health authorities as well as the BC Ministry of Health, and also our national partners, Public Health Agency of Canada, NCCDH, as well as the Public Health Association of BC and the Ontario Public Health. And so it's a large collaboration, and as I said, we work together from the inception of this project. So the idea is, what we did is we identified what were some of the key questions that were of concern to people who were working in public health, and that's how we identified all of the research questions and then worked through all parts of the project with them. So the main overarching goal of the Equity Lens in Public Health is to guide and inform learning about the integration of an equity lens in public health and contribute to knowledge of health inequities reduction. So in British Columbia, in about a decade ago and ongoing, there was an explicit directive in our guiding framework for public health that a health equity lens should be applied to all programs. And that's what really mobilized this program of research, because people said, well, what exactly is a health equity lens? And as well in other provinces like Ontario, for example, we've worked with Ontario where there's clear identification of the importance of identifying health inequities and including health equity in public health programs, particularly through the equity-focused health impact assessment. So the specific objectives of this study are actually the research questions, as not the objectives, are what are the ethical issues of public health practitioners who undertake work reducing health inequities or promoting health equity in the areas of mental health promotion and prevention of harms of substance use. So in British Columbia, we have 21 core programs that are often combined and inform the delivery of public health services in BC. And so we picked 2 of those programs at the advice of our partners as an area for exploring health equity, and in this case, ethical issues in doing health equity work. And then secondly, our second question was, how do public health practitioners navigate these issues? We undertook a grounded theory, which meant that we did one-on-one interviews, and we collected the data and analyzed the data concurrently using constant comparison analysis. We did this together as a team where we compared incidents within the same interview, incidents and statements across interviews, and then incidents over time. And so that gave us a basic thematic analysis, which we then used to produce a grounded theory, which I'll tell you about in a minute or so. We talked to individuals we talked to public health staff who had responsibilities for promoting mental health and preventing the harms of substance use. And so when we say direct care, what we mean is that we talk to people whose main responsibility was delivering care or delivering programs, might be more accurate, or public health services, so they were not in management positions. As you can see from, we did semi-structured interviews where we asked people about their work related to health equity, and then what kind of ethical issues they encountered, and it could be issues where they felt there was a conflict of values, or where they were uncertain about the right thing to do, or they knew the right thing and did not feel they could act in the way that they wanted to. You can see that there were 28 female, 4 male participants. That's how they identified. Majority, all of them had post-secondary education of a 4 had a certificate diploma, 20 a bachelor's degree, and 5 a master's degree, plus 2 currently in a master's program. The majority, 25 of the participants, were RNs. They had on average 6 years in their position and on average 10 years in public health. So these were a pretty experienced group of practitioners. So what you see in front of you is a depiction of the grounded theory that we produced. And in a grounded theory, you're looking to produce an understanding of the basic social process of how people undertake or move through something. So this was the process of navigating ethics in health equity work. And the basic social process we identified was described as navigating different agendas. So from all of our analysis, what we identified is that, people in public health who are encountering ethical issues in health equity work, largely what they're trying to do is work through and navigate a variety of ethical issues. And so what I'm going to do is talk a little bit about 4 very interrelated pieces of this process, and we'll describe each of them in depth. So I'm going to start with the ethically challenging situations. So these are the things that practitioners identified as ethically challenging. And those could be at a very, you may notice the dotted circles where it says intrapersonal, interpersonal, organizational, or systemic. So they might be navigating different agendas across the individuals, with other individuals they work with, either in their program or outside with other programs in the health system or with community agencies. It may be navigating within the health system more broadly, or it may be more related to broader systemic issues in terms of what kinds of services and programs are funded and available. So I'm going to start with the ethically challenging situations, and then I'm going to talk about sense-making, taking action, and on the far right, you'll see the triangle that describes impacts and how these are both, I'm going to present them linearly, but they are definitely interrelated. So we identified, and again, I just want to say this is a preliminary analysis, and I think I'm going to be really keen after I share a bit of the ethically challenging situations to hear how these fit with your experiences, because I've said this is a preliminary analysis. So we identified 4 broad areas of ethical issues that public health practitioners had to navigate in order to work to prevent harms of substance use and promote mental health. These issues were part of practitioners' everyday practice and reflected tensions between the priorities of goals of promoting health equity and often dominant discourses that operate and influence the delivery of public health. The first one I'm going to talk about is providing individual person-centered care versus providing care in situations of structural vulnerability. So individual person-centered care versus providing care in individuals in situations of structural vulnerability. And here practitioners described 3 kinds of issues. And a lot of these issues had at the root or core the fact that healthcare organizations have a person or patient-centered care agenda as a central value, but it's often understood in relation to individuals and fails to account for the social conditions in which many people live thus ignoring the structural vulnerability for those who do not have resources and access to the determinants of health and are experiencing health inequities. So one of the first ones was judgment, stigma, and discrimination, and practitioners repeatedly described a broad range of stigma that they had to navigate and encounter related to both substance use addiction, mental health, mental illness, as well as conditions such as HIV, along with stigma related to poverty. Secondly, they had to navigate issues in which the care they were to provide was based on ticking a checkbox or completing a checklist that, again, did not account for the structural conditions that are shaping the health of people experiencing health inequities. And thirdly, practitioners often identified that they were having to navigate whether they would preserve trust in relationships versus social control, or in some cases they described it as surveillance or policing. And I think sort of inherent in this, and this might be another maybe more accurate title for this issue, was the tension between protection agendas and autonomy. So it could be protection of the public, or it could be protection of the client, versus the client being able to make an independent, autonomous decision about whether they were going to, follow through with care. So I'm just going to give some examples of each of these ethical issues by giving you an example from the data. So the first one talks about this issue of stigma that really impacts people's ability to access services, or even to be well cared for, or even seek out services because they were fearful of encountering stigma. So the first quote is from a practitioner who says, "I find there's more judgment, not having the same kind of emphasis or compassion or understanding of the complexities of health inequities and the determinants of health. Even though that is part of the lens in public health, there's still sort of this certain attitude of like they choose this just for themselves." And so what they're talking about is the kind of approach that tends to blame people for their problems and see them as individual problems. And I think there's a second practitioner, and I just want to share with you a bit of what she said, because I think it really describes how these stigmas are not simply something that individuals have or don't have, but they're actually deeply embedded in our systems. And this person says, "I still think those stigmas still hang out there," and she's referring to the health system. "If they're out there in the world, doctors or nurses or who is ever in the healthcare system, we sort of internalize those, right? And then I think we play them out. They get played out in the care that we give if we haven't thought a lot about it. And sometimes, even when we have, we kind of, there's this whole social construction thing. We bring our socially constructed and accepted narratives to the work we do, and that reflects how society is. And how we act often is a reflection of what society thinks about people. And then she gives the example, she says, about the eye rolling and all of that. So it can be quite subtle, the way that we judge and marginalize people. So she's talking about it, stigma as a systemic kind of issue that plays out in kind of day-to-day interactions. But I want to go even a bit further than that, because although that person is speaking about the stigma in society, playing out in healthcare for people who are experiencing health inequities, the second quote on your slide, and I think the work we do is also stigmatized. Like, our clients are stigmatized for their health and social status, and we're stigmatized for working with them. And so there's, in the literature, there's discussion of what's called stigma of allyship. In other words, when something is highly stigmatized, like mental health or substance use or poverty or HIV, it's actually also applied unfairly to people who provide services. The second concern was related to checklists and checkboxes, and that care needs to be provided based on filling out a checklist or a checkbox versus what people actually need. And here's an example. Certain mothers who quote unquote qualify for a home visit due to some varying risk factors. And is that an equitable way of treating our population? Because it leaves out aesthetic way of knowing about the person. You know, saying, I just have this feeling that this mom needs a visit, or just from the tone of her voice, I think she's not telling me she's depressed, but I sense something. So I go out for a visit, and sure enough, there's several things, different things going on. And this was related to who qualified for a home visit from a public health nurse postpartum, and the concern that, you know, the nurse couldn't, had to just sort of tick the boxes to see who qualified, recognizing that there would be individuals who would also require services, but actually didn't meet it. And this probably came through on many, many programs, and I just chose this one around public health nurse home visiting. And then the third area of preserving trust in relationships versus social control. As I mentioned, this could maybe more accurately be described as a whole set of issues about protection agenda versus autonomy, and the difficulties of ensuring that you know, the public or the client was safe and received care versus making decisions, autonomous decisions about whether or not they would get tested or whether or not they would follow through with something. And in many cases, what was underlying this was trying to navigate what was in the best interest of the person as well as the best interest of the whole population or families. There were quite a few examples of where these involved, you know, parent and child well-being, some involved around infectious diseases and population health versus individual clients' decisions. And the example that I chose on this slide, again, has to do with public health and, in this case, a well baby follow-up. And this person says, in the times where I felt my ethics have been compromised is where I've been asked to have quite a specific follow-up. Like, you know, one example would be to call the doctor to make sure that the client attended for a baby checkup or something like that. For me, I don't feel, I mean, if that was an agreement I had with the client already personally, I would feel okay about that. But for me, as maybe we've never even met, that feels like policing, and that's unethical. And I think this is where individuals highlighted, you know, that they felt like they were torn between the relationship and, you know, following up with someone because of the sensitivity, you know, that you're just checking up on them because of their social situation. There's a wonderful comment on the sidebar, which is what was distracting me from Julie, and she says, could we imagine an approach that is both patient-centered and does not ignore the systemic aspects of the patient experience? I also see this kind of structural vulnerability, myopia, in the patient autonomy. That's actually just a beautiful, thank you for bringing that forward, because I think when we get into one of the other areas, which is around the lack of a systemic health equity lens, and your comment makes me think I probably should have discussed that first, is that these kind of individual issues are actually deeply embedded in a system that does not have a vision of structural vulnerability, and I think your term structural vulnerability myopia is so good in the sense that it brings forward the fact that our system actually has myopia. And when I present kind of the next ones, I hope you'll see that just a little bit further. And so this is one of the second major issues, was doing health equity work on the ground without a systemic health equity or social determinants of health lens. And I think this brings, Julie, I'll look forward to see your comment to see if this resonates a little bit more, because I think this does take a view of being able to see the structural vulnerability of the individuals. And you were quite right to say that in the previous ones, it doesn't quite bring it out. And when I get to the end, you'll kind of see why. So I'm going to talk a little bit about this, doing health equity work on the ground without a health equity or social determinants of health kind of lens. So this is an example of where someone is pointing out the challenges of trying to work with individuals and how stuck they feel, because, you know, you can't give people a better house, you can't give them a sink, you can't give them the basic needs. So you're very torn and almost feel guilty at the end of the day when you go home and you think, like God, you know, you stand in question of what you have and what you need and what people in society need. And so this person is pointing out that there's no capacity within the system necessarily for those resources that people need for health. And, you know, there were many examples that highlighted stories of, I'll just give one case where, you know, the participant was trying to help a youth in a rural community leave a risky situation where they were being exploited, but she couldn't find emergency housing for that individual. And she says, the client's now missing, and I think the client has probably returned to an exploitive situation because that was the only option. And she goes on to talk about how that impacted her because there are no solutions. And she says, I probably cried for just hours that weekend. In other situations, there weren't a lot of examples of this, but examples where you know, someone shared that, you know, a client was actually considering whether or not, you know, the benefits of becoming infected with HIV in order to qualify for services. And so this quote from this person really highlights even more deeply the issues. It's not simply about the material determinants, but understanding some of the issues that people face. So the people I work with who have been drawn into a life of poverty and heavy drug use, I want to know what brought them there, and I want to focus on how did that happen, what went wrong. Not what's wrong with their drug use. Their drug use is really a red herring, and it's a coping mechanism. What was the trauma? What happened? And to me, I'd be looking at what's wrong socially, what's wrong with our political system, sort of the big structural issues that allow people to get sucked into a life that's so unpresent. And I think this really focuses on some of the issues related to stigma, related to discrimination, and how health inequities are produced for some people more than others, and looking more deeply. And she's using, I think, you know, the example here of substance use, and, you know, our programs focus on the substance use as opposed to focusing on the trauma. In many cases, participants identified that there was a lack of mental health substance use services, and I'll give you a couple of examples. Around mental health, it was particularly for postpartum depression, youth mental health. You know, if they identified someone in public health that needed rapid access to emergency health services, those were frequently not available. And related to substance use, a key area where there was a lack of services was around harm reduction services, and very deep understanding sort of around not just the inability to access services, but also the inability to access a range of supplies, lack of safer spaces for drug use, and a lack of harm reduction philosophy. I love the quotes on the side, so we'll waiting for the discussion. A third area of issues that people encountered were tensions in enacting the public health role. And a lot of the way that these could be understood is tensions between different agendas within the healthcare system or agendas within public health. And so one of the first ones was the tensions between primary care and public health. And there was a poll for public health to be involved in primary care, and it's an interesting tension. This person says, and it's a tension that I've always felt working in public health, and she says, you know, as a nurse, there's a lot of things that she could do that would actually help her to build relations and open up the door to doing health promotion and prevention work. And in this example, it was particularly in schools, if she was able to do a primary care role, but the concern being that she would get sucked into the primary care role. There's also tensions between acute care priorities and health promotion prevention priorities. So oftentimes this was experienced as a lack of value for health promotion and prevention, being drawn into what were immediate or acute situations, or of course at the level of funding, health promotion and prevention not being funded. Within public health, there were important tensions between targeting populations and universally accessible programs. And this really ties back, you can see how interrelated they are, to this idea of who qualifies for a program, the checklists and check boxes, and the fact that there was a loss in many cases of universal programs for people, and so that only services were being provided to those who were the worst off, that many people across the social gradient were no longer able to access public health services or benefit from public health programs. This particular quote, I think, brings several of these tensions together. The individual says, you have a kid who's sleeping on the street with a guy. She hooks up with that man for some kind of protection. She doesn't have a lot of power to advocate or to say, I want to use a condom. So if I go in there and say, here, I'm going to give you some condoms and teach you how to use them, that's really naive in terms of the big picture and probably putting her at risk. I would say my job is to try and get her stable housing. So getting her housing is HIV prevention is the way I framed it and still do. That is what my organization has a lot of trouble with. They want to know how many tests do I do. So what's counted and valued is the test versus the work to actually change the conditions of risk around STIs. So I just want to pause here. I've presented to you three kind of very broad categories of ethical issues, and I just want to ask you to reflect and add your comments, if you wouldn't mind, in the chat box around whether or not the ethical tensions that I presented capture or resonate with your experiences of public health. And I just want to acknowledge that we were talking to people who are doing mental health promotion or else prevention of harms of substance use. So in other words, harm reduction work. And so it'd be interesting to hear whether the issues that you encounter resonate at all, or whether they're quite different, because some of the ones that we were putting forward had to do, you know, around particularly things like STI testing or harm reduction work, as well as work with parents and families. So over to any comments in the chat box. It looks like people are typing.
It's Mike here. As people are typing in their comments on the discussion points, I've got a question from earlier on, just a clarification about the grounded theory image that you presented earlier. Lise was asking, what does the CPHC stand for on that graphic? It's a tiny text on the outside of the intrapersonal circle, I think.
Oh, what an astute question. It stands for critical public health consciousness, and it's a part of the grounded theory. I'm going to touch on it at the end because I think it relates very nicely to one of the comments identified earlier, is that, you know, individuals have broader and narrower views of what they see as ethical issues. And I'm not, without saying too much more, I'm going to save a bit more to say about critical public health consciousness at the end. I'm just reading here. I work in HIV. Viral suppression is our focus. And oftentimes the focus on biomedical interventions overshadows the need to change the inequities that make it difficult for folks to achieve. Thank you so much, Lydia, for that comment, because I think that captures what exactly I was trying to say. And I think it comes through pretty clearly in our data as well. It's that biomedical focus on the communicable disease as opposed to the social determinants that they need to achieve, as you say, viral suppression. Breastfeeding promotion sometimes feels stigmatizing to parents who cannot do it, yet it's a public health best practice. If moms have to go back to work early in her baby's life, she may not be able to keep breastfeeding.
Here's an earlier question from Michael, and it was echoed by Hannah just a moment ago. Michael asked, he said first he agrees with Julie, and then he asked, does the study look at the social locations of participants, respondents, ethno-racial, gender identity, abilities, disabilities, sexuality, etc., to best understand the findings? And
yeah, that's a very good question. And we have in the demographics, we only have gender data and we have public health experience data. But as we spoke to people, we did have very clear points at which people identified in terms of either, in one case, just thinking of the specific example where the person identified as I'm just trying to recall specifically how many we had around this, but people would, for example, identify as LGBTQ, and they would locate themselves in that way. But I think the kind of analysis that you're asking for in terms of their social location, I'm not confident that we have enough data. What we did identify, though, is people found it very tricky that if they identified with a particular racialized or a non-dominant group, so if they identified as LGBTQ, they described to us how they had to very carefully navigate their position within the organization so that they weren't subject to the same kinds of norms and stigma. Because I think what comes out overwhelmingly in the data when people are talking is the way in which stigma is deeply embedded in the system regardless of what social positions and locations. But I think that would be an important follow-up question.
A fairly straightforward question appearing on the screen from Charles. It's what is structural vulnerability myopia? Maybe you could just touch on that for a moment, please.
Well, I have to say, until Julie put out that term, I think you put it out today, and I see Christina's responded. In our work, we talk about structural vulnerability, and I hadn't thought about, we described as people either seeing the structural conditions and the vulnerability that's produced within it. And so structural vulnerability comes from a lot of work by Paul Farmer. It comes from work by Casada, who talks about actually structural violence and the fact that structural conditions are what produces vulnerability for individuals. So you can think about things like, the failure to build social housing, colonization, policies that, discriminate against individuals are all structural part of structural conditions that then feed in and produce inequities. And I love, I think, again, thanks, Julie, structural vulnerability myopia, the fact that practitioners don't see the structural conditions that are producing the inequities, which is why this issue of systemic stigma, I think, is so big. Someone just made a comment, Kim, about, the ethical challenge around the fentanyl crisis. And one of the ways I think about that in terms of health equity and inequity is that we actually have a set of federal policies which criminalize certain types of substance use that creates sweeping inequities across the social gradient, where some people are criminalized more than others, and where we have inequitable implementation of services that would address those harms as well. Thanks, Cynthia, for your comment. Again, back to the structural vulnerability myopia as a counterpoint to lifestyle drift. You're right, it's people don't see it. And I hadn't thought about it in terms of myopia, but it's perfect because I've got actually written it up as seeing or not seeing structural vulnerability as the ethical issue. Just wondering, Michael, should we continue or is there one more question?
Sure, it might be time to move along. There are plenty more opportunities for questions. So, yeah.
Great. The time is flying for me. I hope it's flying for you. Here's again the grounded theory diagram, and we've talked about the ethically challenging situations that occur at multiple levels. And then the way practitioners navigate through that is by trying to make sense of these situations and taking action. And sometimes they take action and then make sense of it. And you can see that sense-making and taking action is reciprocal with impacts, because there are multiple impacts that occur throughout the process. So in a way, this is not a linear example. So the way that people make sense of these ethical issues is they work very hard to understand and appreciate the population that they're working with. For one practitioner talked, for example, about when she was a student, I didn't really much appreciate a person who was using drugs or working in the sex trade. She said she felt she had a lot of stigma around that. And that's where over the years, she said, it's been unlocked for me. And in her work in public health, she started, and working with people, she started to identify how inaccurate that kind of stigma is. And she relates it a lot to the fact that people haven't had a lot of exposure, but once you hear people's stories out there, it changes your perspective. So that was her particular point of view, and that many individuals said, I didn't actually learn about, drug use policy, or I didn't learn about, enough about kind of poverty or other aspects of structural vulnerability. Another way that people made sense of the situation was to learn how to put it into kind of ethical terms. and putting it into terms of health equity and social justice, and recognizing that there was a set of ethical language that's actually different than what we're taught around the typical language related to autonomy, beneficence, and non-maleficence. Another example of making sense was to stay grounded in their collective values. And so this was staying, we work in public health. We're committed to, the values of promoting health of the population and preventing health inequities. And so staying clear, that's why we're here. That's what we're here to do, regardless of what kind of the system says I'm supposed to do, or the program says, or even if individuals are not necessarily engaging with services. Persistence was really important, so seeing the small steps that could be taken with a client and continuing to persist. And this was related, in some cases, to many, many, many years around working with someone and seeing them, moving forward and falling back, like in the case of a mom and family. And then situational thinking, which really relates to this idea of structural vulnerability and understanding how people are situated in their structural context. So the next quote ties up, I think, nicely this issue of persistence, but also of situational thinking. And so it says, I guess for this woman, I've seen her with her children for 7 years. I've seen her when she's been sober and parenting. And this was like the lowest she'd ever been, and that she'd lost everything. And it was crystal meth, a nasty drug. I know the potential that I've seen. I guess I've seen that person, and I know where she's been and where she's at, and that the potential for her is still there for her to do that. And, how she continues to navigate through this situation. So I'll just stop there briefly if there's anything you want to add in terms of how public health practitioners make sense of ethically challenging situations. And I've given kind of a high-level overview. One of the things that I probably just touched on too lightly was, and it'll come up again in taking action, that when people are grounded in their collective values, it's often a source of support and resource as well. I'm seeing no questions. The next part is around taking action, and I'll just pull out a few things in terms of how public health practitioners navigate through some of these ethical issues. Obviously, whether there's opportunities formally within their program or not, they focus on working upstream. And so, and it comes up a bit later again under doing what it takes, in that individuals will do what it takes in order to help someone find housing. So for example, when people have stable, safe, and secure housing, then the chances are going to be successful in following through with mental health support, their HIV care. The chances of that happening will be greater percentage-wise, and people will be more apt to start looking at their addictions as well. But it all comes down, and for this person, it all came down to safe and stable housing, and they're interrelated with mental health, with addiction, with poverty, and getting that piece in place, then they're more able to be motivated to take care of some of their other needs. So the individual then focuses on working upstream. Advocating for clients in the system, but I would say advocating was an area where people felt very, very challenged because they often felt that the advocacy function they had was being lost, and they would describe it as having to fight the system, so also a very large battle. Being client-centered, staying client-centered, so that's staying in terms of grounded in terms of what the client needs, talking things through together. This was a huge area of ethics resource that people felt if they had colleagues and people on their team that they could talk through what they needed to do, and felt that support from their colleagues really made a difference so that they didn't feel quite so alone. And then doing what it takes. And, you know, in some cases, one example was distributing harm reduction supplies in an organization that didn't support harm reduction, but knowing that clients would be better off. The concern being, of course, that they were at risk of not being able to continue to work with that kind of agency. And then in some cases, using what they called survival tactics, and sometimes that meant, in some cases, if it became too much, people would leave their job, or they would change their job, or they would sort of limit their view a little bit of what was ethical issues and sort of to be able to continue to survive. The last area of the grounded theory is around impacts, and there are impacts on clients, practitioners, and then the system. Whoops, the one on actions is the discussion point's in the wrong place. I think I'll leave that one for right now and just go over the impacts. So in terms of impacts, I started to sort of identify some of the impacts when, you know, clients identified how they would survive. The idea of there was a lot of impact on practitioners around witnessing health inequities and not being able to do anything about it. And so feeling a lot of distress, and I think to put it in terms of ethics, around moral distress, often seeing what the client needed but not being able to do it. And so that's how moral distress is often defined. Biting the hand that feeds you means taking action and attempting to work through and take action even though you know you might be sanctioned by the system, or finding a way to live in kind of a middle ground where you don't alienate the system, but you stay in the system and make the changes that you can. There are obviously impacts on clients in terms of their needs not being met, or if the practitioner was able to do that, their needs being met, or actually harm to the client rather than preventing harm. And I would say the greatest system inequity was that barriers to care, and there are many, many barriers to care for this population, continue to exist. I'm just going to give you a few examples of the impacts on the practitioner, and the three I mentioned, the first one being witnesses, when they don't have power to address those determinants of health, when there's very little systemic responses to address the determinants of health, and then of course concerns about compassion fatigue and burnout, which is very similar to, you know, health ethics literature, other types of ethics literature. So biting the hand that feeds you, and this was from the person who described that there was only bleach and condoms being used in a program, and so wanting to provide people with clean needles, but concerning that they would be no longer able to provide services if they did that too much or too kind of often. Some people said in terms of biting the hand that feeds you, where you're going against employers' expectations and priority, you do first, ask forgiveness later, retreat from the dialogue, because that can be futile, and actually, you know, determining if it's a job limiting kind of action. And in this case, the person says, I don't know my manager would feel the same way, and even if my manager told me I shouldn't have done it, I personally wouldn't see it as a mistake. I would apologize if she told me it was wrong, but I want to keep my job. And so making those kinds of discernments about, you know, how will this impact if they actually take action in the system. And I can think of the individuals here aren't specifically talking about things like overdose prevention, but because I work in that area, that's one I can highly, relate to when, there are varying levels of support within organizations for harm reduction, such as overdose prevention sites. Here's an example from someone that describes how they live in the middle ground. This is how they navigate it. And I live in the middle ground, meaning there are certain limitations to my work I have to accept if I'm going to work for this organization, which there are lots of perks, including a nice stable paycheck. Whereas if I quit and work for a community organization, for example, where you get to be a bit more radical, some of those perks are gone. So looking at what can they do within the organization that they're in to try to move forward. So I'm just going to stop here and see if there are any questions or comments about sense-making, taking action, or the impacts before I go through some of the conclusions.
There were a couple of comments from earlier that I'd like to share. One was in the context of sense-making. It was from Magali. I do believe it was there that she said clinical supervision every week to discuss client issues and to ground us within an equity framework. That was one way of sense-making.
Thank you, Michael. That's a really good example, because I think what we would like to do as a result, or what we're going to do, not we would like to do, what we're going to do and compelled to do is to produce some frameworks for practitioners to be able to identify and navigate ethical issues in their practice. There's a huge focus in clinical care about kind of weekly ethics rounds, and I think what your comment highlights would be the value of the same kinds of things in public health, but grounded in a health equity framework, as opposed to, the typical kind of acute care clinical ethics frameworks.
And then just a moment ago, there was another one from Maureen, and I think this is in the context of taking action, but it might also fit in a bit with sense-making and straddle them both. She mentioned using stories to illustrate what clients are dealing with. That can help with the advocacy, and it provides some opportunities for dialogue among colleagues.
Mm-hmm. And I think that's a nice extension. Like, individuals talked about stories mostly in the context of their own learning, but I think what your comment raises for me is, how do we bring those stories to expand understanding within our systems, and how do we more directly engage in health equity work communities that are affected and experiencing health inequities, and how, and what I reflect on is that is very basic, not basic, but it's very well understood aspects of health promotion and community development, which I would suggest, in my experiences in public health, have been lost in many ways.
We're just approaching 10 after, so I will leave it to you if you'd like to take one more off of the screen, or if you'd like to just continue at this point, based on what you have yet to cover.
Just having quickly look. There's lots of great comments, I think, about stories and how we can use them, and then I think engaging with partners. And I don't know if individuals would want to comment on this, where Maria has said collaborating with larger partners for advocacy purposes. One of the things that we find, and this is a BC-centric comment, is that there isn't a lot of support for practitioners within public health to do intersectoral and advocacy work, but that might be very unique to BC, as all this data was collected in BC. Yeah, very nice comment there from Catherine about how it goes both ways in terms of biting the hand that feeds you, and how we use that as a way of, I think that's where there's a lot of reciprocity between sense-making and taking action, is that, people sort of are making very measured and careful decisions about when and where they can act in the immediate and how it might jeopardize in future. And I think bringing those stories forward is important as well. So the last thing that I want to touch on is what someone identified earlier was on the first slide around the critical public health lens, which you can see on the current picture is kind of the light blue lens that is just around the intrapersonal. And this lens, having a critical public health consciousness and seeing structural vulnerability versus what I'm now going to describe as structural vulnerability myopia, is that lens can be wider or narrower for practitioners. And what people in this study identified is that that actually was an area of difficulty, because if they had a very broad view, very critical public health consciousness, and they saw this structural vulnerability, it was hard to sometimes work with their colleagues and under other organizations who had a much narrower view or were more myopic in terms of structural vulnerability. And so the varying degree, here you see the critical public health lens encompassing a broad range of ethically challenging situations and issues versus a more narrow one. And oftentimes the more narrow one can actually be a way of surviving in an organization. And so I'm just going to end with a few thoughts and then any final comments. In our analysis, there are opportunities for public health to take action on social justice, and that these are grounded, these ethical issues are grounded in their commitment to health equity and social justice and in everyday practice, and that a lot of our duty to act and our actual experiences of this come from our situated position that is proximal to service providers' lived experience, and that practitioners routinely experience ethical concerns but have few organizational resources available to support ethical public health practice. So if we do want to link this, you know, a grounded theory, we've proposed a theory of how people name and navigate ethical issues. But I think when we, in a grounded theory, you often do go and look and say, is there anything existing? We identified relational public health ethics developed by Baylis, Kenny, and Sherwood as a promising approach to ethical public health practice, a relational understanding of persons that acknowledges the way we are socially situated and independent and sees solidarity as the key public process across which we do collaboration and are transparent and accountable in our decision-making, the understanding that we are all in this together. And to me, that would be a pretty radical shift in organizations to move towards a principle of solidarity in how we work, and how would our systems then have to shift and take on greater understanding of structural vulnerability and a greater public health consciousness. So sitting between the system intention and the actual impact on the client, the practitioner often can report on the coherence between goals and effects, as well as being able to focus on and identify ethical issues as well as strategies for addressing ethical issues in public health work. And this is from Baylis and Sherwin asked us, sorry, Kenny Baylis and Kenny, Sherwin, and Baylis. I got to get the right order. They have a couple different articles. And so actually Nuala Kenny was my postdoc supervisor, so I had a chance to work with her at that time. And I think they really bring out asking us to look beyond the effects on individuals and see how the member of different social groups may be collectively impacted by practice that create inequalities in access and opportunity, and enjoins us to correct patterns of systemic injustices among different groups, seeking us to improve rather than worsen systemic disadvantages in society. So we do have a final discussion point, but I would say, you know, if you have any comments or questions, we would welcome hearing those, because we have about 15 minutes, or if there's none, we can certainly finish early. So, Michael, can I turn it over to you, because I haven't quite seen all the comments as I've been talking.
Sure. There, I think, have only been a couple since the last one you addressed, but there's one on the screen from Maureen, which I think is interesting. I think Ontario might be slightly different than BC, is working collaboratively within sectors. I also know that at my health unit, we are working very deliberately to increase the dialogue around ethical issues and then pushing action. Action may be in small steps, but by raising the issues, more public health practitioners are becoming engaged. An interesting comment, Maureen. Thank you.
That's very helpful, Maureen, because I think the way that public health is organized, it really, as you're describing, makes a difference. And so you can, you know, a lot of what I've been presenting is really turning back to the systemic injustices. It's not simply at that individual level, because that would be a very kind of narrow public health consciousness around ethics to only look at, you know, what's happening in the interface between, you know, programs and clients. The big issue is flipping back and look at those systemic. So it's great to hear your comments. Ooh, what a great question there. And I apologize if I say your name incorrectly, Waku. Do you plan to expand this research to look at similarities and differences between the perspectives of senior leadership compared to practitioners on the ground? That's a fantastic question, because through our whole ELF program of research, we have looked at similarities and differences between senior leadership and practitioners in terms of whether health equity is a priority, what influences their ability to implement health equity, how they understand and view health equity. On the ethical issues piece, we have not specifically talked to senior leadership, but I think your point's well taken. That's a great follow-up or next project for someone, not necessarily us. Thank you.
And here's a comment from Bill. It's on the screen. It's about multi-sector or intersectoral work happening in Ontario through the Healthy Communities Initiative. Apparently, they're doing a good job of engaging public health as an important voice among other partners to enact systems change. For example, Health Ontario. I'm not sure if Sume, if you've still got the phone connection, but if you have any comments that you've pulled out from earlier on, please share those to me.
Thanks, Michael. There's a comment from Michael, and he's talking about how the system supports practitioners. His comment is, there's a real lack of proper funding and supporting of equity training and capacity building, not as a one-off, but on an ongoing, regular, and mandatory basis for all staff within any given workplace environment, and not just for frontline practitioners. So thanks for that comment, Michael.
Oh, Sume, I just noticed just above Michael's comment, there's a really good question from Dee Goslin. How do you balance your code of ethics between your professional and organizational values? And I really thank you for that question, because in nursing and other professions where we have a code of ethics, we are often not able to enact that code of ethics because of organizational or even provincial or federal guidelines and policies. And the best example I can give you from my own work is we identified that the inability of nurses to provide harm reduction supplies and services and to take a harm reduction approach in their practice was actually aligned with professional codes of ethics and practice standards, but organizational policies and provincial and federal policies left them caught between these systems and unable to act. The power of naming that as an ethical issue was profound because we were able at the national level to bring this forward to highlight how harm reduction was consistent with professional and ethical standards of practice. The Canadian Nurses Association was one of the main interveners at the federal level around insight and seeing it established as a healthcare kind of service. So I think on the kind of more macro level, your codes of ethics can actually be brought forward in that big way, but they can also be brought forward at the micro and meso level in terms of using those codes of ethics and practice, our professional standards, to point out how you are unable to act ethically because of organizational or other types of policies.
We have a fairly resonant comment here from guests. It's about 3 from the bottom. I'll read it out. I think it's worth hearing. If we replace public health professionals for, quote, therapists, unquote, in the quote from Charles Waldegrave from New Zealand, quote, when people come to therapists depressed and in bad housing, and therapists treat their clinical and or social problems within conventional clinical boundaries, they're simply made to feel a little better while continuing to live in poverty. Mm-hmm. Quite often, competent therapists are able to quite effectively help move people out of depression, but then simply send them back to the conditions that created the problems in the first place, unintentionally, but nonetheless very effectively. They simply adjust people to poverty. That's a structural problem that could be seen to exist across several sectors. It's certainly one for public health. I think it's an interesting comment. Thank you, guest.
Mm-hmm. It's a great comment. Because I think why public health is so important is because we're pushing back against that or working to reduce those inequities. This is just a quick kind of comment from me. As I read through the comments, and I've tried to read as many of them I can, what I'm hearing is that our examples, and I feel sometimes when I present it, I haven't captured the richness of what people have identified, but when I look at your comments, what I'm seeing in the comments is that these examples do resonate, and that this issue of structural vulnerability myopia, thanks Julie, has meaning and resonance for people. And also the other aspect of this that several people are bringing out is where their public health work is really seeking to address it, as well as this last discussion in terms of commenting, you know, where it's not doing that. And I really like it in many ways. What those comments do is they buoy me up to recognize, you know, public health takes this work of health equity extremely serious. And Fran Baum has a great comment where she says, reorientating the system to health equity is not for the faint-hearted. I see a lot of, what buoys me up is the courage in the comments. So thank you very much.
I'm going to propose that during the last 4 or 5 minutes that we have available to us, I take us through the last 3 or 4 slides. And if Bernie, you'd be willing and able to respond to what comes up in the chat for a couple minutes, I'll just go through the last couple things, and we'll see if the discussion continues. Would that be okay?
Good with me, Michael. Thank you.
Okay. here's some contact information for the health project at UVic. Questions and discussion, don't let me stop you from typing. Your comments are fabulous, and I'm really sorry we can't get to all of them right now. Here's one for Sume.
Thanks, Bernie, for your presentation. This is just information on how you can reach the NCCDH. You can check out more of our workshops or webinars. Our next one, I believe, is in a couple of weeks. For those of you who are francophone on the line, we're doing this again next week, I believe, in French, so you can invite your colleagues to join us. Also, we have a resource library where you can find health equity resources, as well as a list of organizations taking action on health equity, and all those are accessible through our main website, nccdh.ca.
Thank you, Sume. I always feel terrible closing off webinars when there are people still talking to one another inside conversations. That's great to see. Here are a few resources from NCCHPP on public health ethics. We have much more on our website, and we invite you to visit that. As well, I've got a colleague in the room, Val Morrison, who's also done some terrific work on inequalities and policy approaches to addressing health equity issues. Our most profound thanks to Dr. Pauly for your talk today. That was terrific, and it's been a real treat working with you on this. I just want to thank you on behalf of DH and HPP. Thanks so much.
Thank you, and thank you to everyone that joined.
And here's the part of the webinar where we implore you to visit and then fill out the evaluation form. Those are very important to us, and we really appreciate your comments in them. They also help to guide our work. For those of you who wish to get continuing education credits, you can go through the evaluation form, and at the end there's a link. There's a link to the how to obtain continuing education credits. And here's how you can contact our respective national collaborating centers. And we also invite you to contact Sume or I directly. We'd be happy to hear from you. And you'll be hearing from us afterwards with the links to the recording and to the PowerPoint. But thanks so much, Dr. Pauly, and thank you all for joining us.